Hey folks, Dr. Garber here. Today we're going to discuss Cox cervical spine procedures. To start with, let's do an overview of the cervical headpiece. So starting with the tiller bar, it is adjustable up and down, and that would be based on doctor's needs and comfort. Right over here, we have the release for cervical spine rotation. If you pull that out and turn it, it will stay in place, and then you can freely rotate the cervical spine, and then it'll lock down again. All right, this knob here controls the width of the cushions, which I put under the patient's control so they can adjust it to their own comfort level. This here releases the Y-axis component of the headpiece. As you can see, it then goes out and back. It can also be locked down in a few different positions, enabling you to lengthen the table for taller patients, particularly when dealing with lumbar disorders. When you start it in the position closest to the cervicothoracic cushion. And then here we have the flexion release, and that is spring-loaded. There's no way to adjust the tension on that. It's adjusted for the average head weight. And then the last one right here is the lateral flexion release. And you can release these on either side, so I'm going to release it on this side. And that allows the headpiece to sway back and forth for lateral flexion mobilization. One other element are the occipital restraints, which are in the front, and these go over and then hook on the underside on another piece of Velcro on the underside of the caudal end of the headpiece. All right, let's get some face paper. There's no face paper holder. There's really no place to put one. All right, and my wonderful daughter Sarah is going to be our subject today. So Sarah, if you would face down. There's a cutout in the foam for the eyes to make it a little more comfortable. And generally speaking, when the patient is there, the mid-cervical spine is in the break or the separation between the cervicothoracic cushion and the headpiece. One thing that's important is some patients, when they get on the table, they go too high up on the table. Sarah, scoot up for me. Keep going. All right, so right there, her shoulders are now going to encumber or limit the free movement of that cervical headpiece. So make sure they're not there. Let's come on down a little bit more and a little bit more. Perfect. Okay, right there. Make sure you have free access to the patient's cervical spine. Very good. Okay, so the first thing we're going to go over is tolerance testing. As it's similar to the lumbar spine in that we're trying to find the treatment start point or an acceptable point where we can initiate treatment on a particular case. The big difference is that for the cervical spine, the initial movement of decompression is Y-axis, it's not flexion. So Dr. Cox discovered this early on when he started to experiment with cervical headpieces. He found that the flexion was just ineffective and oftentimes too much for the patient. And so Y-axis is the initial movement. And that is the only movement that we tolerance test in. So we tolerance test starting at the occiput all the way down to C7, and then we repeat it with the restraints on. And that gives us an idea of where we can start and how much pressure and pull or tension the patient can tolerate. So let's show you exactly what we're talking about. So we're going to release the y-axis component. The grip is a pincher grip. It's a fairly wide pincher grip. And you're trying to get the interphalangeal joint of the thumb and either the distal or the proximal interphalangeal joint of the index finger. If we're talking about a vertebrae, it would be on the lamina pedicle junction. But we're going to start with the occiput. So we're going to take that web contact and put it directly under the occiput. Then when we do that, we want to lift up a little bit because we do not want to put any P to A pressure into the cervical spine for any of the procedures. All right, and once we do that and we've lifted up, then we make sure that the arm is going up the long y-axis of the spine, and the tiller bar hand and the contact hand move together. The doctor is in a fencer stance, and he uses his weight or his center of gravity to bring the segment that's being contacted, in this case the occiput, to the area of elastic resistance, which is right there. We hold for 4 seconds and inquire for provocation, and then we release, and then we come down to the atlas on the lateral masses, and we lift, and then we go to the area of elastic resistance, hold for 4 seconds, inquire for provocation, and release. And then we drop down to C2 and do the same. So again, wide pincher grip. My thumb, the interphalangeal joint, is on the right lamina pedicle junction of C2, and then the proximal interphalangeal joint of my index finger is on the left lamina pedicle junction of C2. And once I'm there, I want to try and get the web of my hand, on the posterior aspect of the skin on her neck. All right, so I'm there now, and then what I'm going to do is make sure my arm is going up the y-axis of the spine, and then I'm going to lift up, and from that position, with equal pressure on the tiller bar and contact hand, I'm going to find the barrier of elastic resistance. And of course, the barrier is that point where all the soft tissue is taut. And once there, we're going to inquire for provocation and then release. And then we're going to do the same thing at C3, lamina pedicle junction, web of my hand on the back of her neck, lift, and straight inferior to superior only. So some things to watch out for. Do not rest your thenar on the cervical thoracic area. I mean, if it's touching, that's fine, but don't put any pressure into it. We do not want any P to A pressure because we found through research that increases intradiscal pressure, and our goal is the exact opposite of that, is to decrease intradiscal pressure. All right, one other important concept is when you have an acute cervical spine disorder with upper extremity involvement, let's say we had radiculopathy into the right upper extremity. Let's say it was a C5 disc level, right posterolateral C5 disc protrusion, causing right upper extremity radiculopathy. You would want to contact C5. That would be the best or most appropriate level to contact. However, you might not be able to. The patient might be in too much pain. And so as you're tolerance testing, you stop at the most superior level that keeps the patient comfortable. In other words, it does not exacerbate their existing pain or cause an increase of pain, numbness, and tingling into the upper extremity. So it just might not be possible to go that low. You just go at the most superior segment that the patient is able to tolerate. Now, with radicular involvement, oftentimes when patients lay in the prone posture, the arm begins to flare. And two solutions for that, or two potential solutions. Number one is putting their arm above their head, like in the Picote's position. So let's say it was a left-sided radiculopathy, and the patient was complaining that they're getting an increase in numbness and pain into that left upper extremity. What you would do, Sarah, let's have your left arm, and let's put it up over your head, just like this. There you go. Right. Now that opens the IVFs on the left side, and oftentimes will relieve the pain or the numbness and the tingling, allowing you to proceed, and you still have plenty of room here to contact the patient's cervical spine and do what you need to. All right, let's put that arm back to the side. All right, there's one other option, and you can do both at the same time, but you can release the lateral flexion lever. I'm going to release it on this side. You probably won't see me doing it, but when you do that, then you can laterally tilt the head away. Again, let's say it's a left-sided radiculopathy. You can laterally tilt the head away and ask the patient, as you do that, if that begins to relieve the pain in the arm or in the neck. And you can do both at the same time to try and get them at least to a comfortable point where you can initiate treatment. All right, so again, you start at the occiput and you work down C1, 2, 3, 4, 5, 6, 7. You would end at C7. If you can tolerance test all 7 cervical vertebrae, then you do that. Make a note in your mind how the patient feels for each vertebral level. And like I was saying, if it's a C5 disc lesion, and when you get to C4, it increases their level of pain in the neck or into the upper extremity, then you would actually have to just limit the contact to C3. Of course, as the patient improves, you'll be able to go to a more inferior contact to C4 and then eventually to C5. But you have to start at a point where the patient is comfortable and can clearly tolerate the procedure. And once you've done all you can in terms of tolerance testing, then you would repeat it again with the restraints. It's an identical procedure. You just put the restraints on. So I'm just going to show you briefly. So the restraints go around the occiput. Keep them on the occiput. Try and keep them off the cervical spine. And then there's a Velcro area right under this caudal section of the headpiece. And then the other one comes around that one. It goes like that. This substantially increases the amount of tension or traction in the cervical spine, and so you want to make sure that you use a little less pressure both with the contact hand and the tiller bar hand. But you would just release y-axis, and then you would start with your contacts. Again, lamina pedicle junction, lift, and then find the barrier of elastic resistance and hold for 4 seconds. Inquire for provocation. Make a note if that level was tolerable and comfortable for the patient. If it was, then move down and you go to the most inferior segment that you can with the patient still comfortable. All right, let's move on to protocol 1. And protocol 1 would be used for cervical spine disorders that have a radicular component associated with them. So again, let's say she has a C5 right posterolateral disc protrusion, and it's effacing the C6 nerve root, causing C6 upper extremity radiculopathy. So your contact point would be C5, and protocol 1 would be the appropriate protocol because that is for spine conditions with a radicular component. So the 5 4-second pumps, or the 3 20-second decompressions with each 20-second session consisting of 5 4-second pumps is what you are trying to accomplish here. Okay, you would have tolerance tested by now, and we'll just say that in her particular case, she was able to handle decompression at the C5 level. So that's what we're going to demonstrate. Okay, so there's VP or C7, there's C6, and there's C5. So with that pincher grip, I'm going to slide down to the sides of her neck, getting a grip on the lamina pedicle junction with the web of my kind of like the thenar web on the nape of her neck, or the skin of her neck. Okay, and then I'm going to make sure this arm, this contact arm, is going straight up the y-axis of the spine. I'm going to release the y-axis lock. All right, and remember the line of drive is pure I to S, but before we do that, I'm going to lift, almost like I'm trying to pull the cervical lordosis up and reduce it. And once I do that, then equal force on tiller bar and contact hand, straight, in this case there's a wall here, toward the wall, straight I to S. All right, and there's the barrier of elastic resistance. Now I'm going to start my first 20-second decompression session. So we're going to go 2 out and 2 back, and 2 out and 2 back. I'm using equal force between the tiller bar and the contact hand. It's very gentle and very subtle. That should be 4. How we doing, patient? Did that feel good, Sarah? Mm-hmm. Okay, good. All right, and that's 5. Okay. All right, so that just finished my first 20-second decompression. Now we like to give the patient a little time to rest, to kind of relax and absorb that. And so you can do trigger points following the involved dermatome down the involved extremity. So I typically start with the levator scap, looking for trigger points. I check the rhomboids. I'll go to the supraspinatus and infraspinatus, and I'll just work my way down the arm and do just some gentle trigger point release if I find one, giving the patient a minute or 2 or 2 or 3 minutes to kind of regroup. All right, then we're going to do our second 20-second decompression. All right, so I'm going to release y-axis. That was flexion. Release y-axis. All right, again, we're going to get on C5. Wide pincher grip. Interphalangeal joints on the lamina pedicle junction of C5. Web of my hand on the back of her neck. Arm going up the y-axis of the spine. Equal force between contact hand and tiller bar hand till we find the barrier of elastic resistance, which is right there. Then we're going to start our second 20-second decompression. And it's 2 out, 2 back, 2 out, 2 back. I feel okay, Sarah? Mm-hmm. Always ask the patient, always inquire for provocation. That's 3, and that's 4. Okay. All right, so we're going to lock that down. And we would do that one more time, giving us our 3 20-second decompressions. And then you would follow with physiologic therapeutics, either interferential muscle stim or high volt galvanic, applied to the area of the disc lesion for 20 to 30 minutes, accompanied by ice to the area if there's a lot of inflammation, or heat if there just seems to be a lot of spasm. And the patient would be seen on a daily basis until they're 50% subjectively and objectively improved. All right, and then the next protocol is protocol 2, and of course protocol 2 is if there is no radicular involvement of the case. So protocol 2 can also be used as a segue out of protocol 1 after the patient is 50% improved. You can begin to initiate levels of protocol 2. I don't like to do the whole thing at once, but let's just say this is a patient right off the street that just had no radicular involvement. Maybe it's an aged individual with some disc degeneration and facet arthrosis and localized neck pain and maybe a little somatic referred pain into the traps or into the scaps, and you want to treat utilizing Cox Technique. Protocol 2 would be the appropriate one, which is basically a technique to increase physiologic range of movement to the facets and generally just improve a dysfunctional spine, get it functioning properly again. Okay, so same contact level. We're going to do C5, same contact with the hand. Again, we're going to release lateral flexion. And now I'm also going to, we just released y-axis and lateral flexion. Okay, we're not going to do lateral flexion yet, but I like to have it released because we're going to be doing it next. All right, so C5 contact, lamina-pedicle junction with my interphalangeal joints of thumb and index finger. Always make sure that you're never putting P to A pressure down into the upper thoracics or lower cervicals. Make sure your arm is going up the y-axis of their spine. All right, grasp the tiller bar, and with equal pressure or tension or push, you go in a straight I to S direction. When you find the barrier of elastic resistance, now you're going to do 10 2-second pumps in y-axis, 10 2-second pumps. I believe that's 5, 6, 7, 8. How's that feel, Sarah? No problem? Awesome, good. So there's 10, and of course that's designed to break up any fixative elements that are limiting y-axis movement at that vertebral level. All right, after we've done that, then we're going to go into y-axis and lateral flexion, one of my favorite moves to do. Okay, so we find the barrier of elastic resistance, and now we're going to do 10 lateral flexions to the left, mobilizing that C5, really C4, C5, C6 area in lateral flexion with everything under traction. Then we're going to bring her back to central, make sure y-axis, that we're at the barrier again. Now we're going to do 10 to the right. Alrighty, very good. Okay. All right, now what I like to do at this point, and it just varies slightly from what Dr. Cox is teaching, is I like to lock the lateral flexion down and initiate y-axis with rotation. And so we take the rotation release, pull it out, turn it a little so that it's free. Okay. All right, so we're going to get right on C5. Again, straight I to S, find the barrier of elastic resistance, and then we're going to rotate. Rotate first to the left. Now remember, we're at the barrier of elastic resistance, so all the soft tissue is taut, and so this is going to break up fixations in rotation, then we find the barrier of elastic resistance again, and then rotate to the right 10 times, breaking up any fixations at that functional spinal unit going to the right. All right, then we're going to release y-axis again. And now we're going to do a combination of rotation and lateral flexion. First to the left and then to the right. Kind of takes a while to get the rhythm going in there. We'll do 10 to each side. Okay, so we're going to lock that, lock the lateral flexion down, we're going to lock the rotation down. All right, and then the final one is y-axis with extension. All right, so in order to do extension, we actually have to release the flexion component, because that now allows this headpiece to flex down and extend upwards. All right, so we're going to again get on C5 and find the barrier of elastic resistance, and now we're going to do 10 extensions gently. For all of these moves, we always stay in the patient's tolerant range. We never, always ask the patient how they're doing. This is a wonderful way to mobilize the spine without HVLA manipulation. It works beautifully on really any age, but particularly well on the aged where they have advanced degenerative disc disease, facet arthrosis, and just general spondylosis and dysfunction throughout their cervical spine. All right, so everything's locked down now. In terms of getting on and off the table, there's no particular tricks. With cervical spine disorders, although they are extremely painful, there's no difficulty ambulating. So they typically have no issues getting on and off. The biggest problem is once they get on, oftentimes if there is a significant radicular component, it's just this position, because it puts the cervical spine into a little bit of extension, that position seems to exacerbate the arm pain. So you can use either the Bacody's maneuver or laterally bend away from the site of involvement. One other aspect of the technique, Dr. Cox doesn't care for it much, and that's the flexion component. He doesn't recommend using it at all for any of those mobilization procedures that we had just shown you. And he just says for doctors who want to use a flexion component with cervical spine disorders is just to take the table into a slight degree of flexion and leave it there. So you can release the flexion component and then just lock it right there. That gives you about somewhere in the range of maybe 10 to 15 degrees of flexion, and you can do any of those procedures that we just showed you with the headpiece inflection. Just use a little less force with your procedures, because that is going to pre-tense the tissues without you doing anything, so you don't need as much force. I particularly don't use it. I do everything in y-axis. All right, one other thing, and then we're done. All the procedures that we just showed you were good for up to C6. And what they found is that trying to contact C7 in this fashion that we had just shown you just increases intradiscal pressure. So if you have a C7 disc lesion with a C8 root involvement, or even T1 with a T1 root, the way it is done is we actually put the restraints on and then we contact T5. We kind of hold and stabilize T5, and then use the tiller bar to do the decompression. That would be easily demonstrated. So let's say Sarah had a C7 disc lesion with a C8 radicular component. We put these restraints on. All right, and then we find T5. Here's our VP, C7, T1, T2, T3, T4, T5, and then I'm going to get a thenar contact on the superior aspect of that spinous, or you can put it between your thenars that way. Either one, whatever you can get a good grip on, and then you're going to release y-axis only, right? So you're going to put pressure down on that fifth thoracic to stabilize it and keep it moving, keep it from moving. Not a lot of pressure, just a kind of a mild to moderate amount of pressure. And then you're going to take the tiller bar and you're going to find the barrier of elastic resistance, which is right there. And then you would do a 20-second decompression session. So you get 2 out, 2 back, right back to the barrier, 2 out, right back to the barrier. Sarah, you okay? That's 3. That's 4. That is 5. Okay. And so again, we would just follow the Protocol 1 guidelines of 3 20-second decompression sessions, each session consisting of 5 4-second pumps. And we would do it in that fashion for C7, T1, T2, T3, so on and so forth. All right, so that's a general overview of the cervical spine procedures.